Hello, everyone. It is time for a student webinar. We have a great topic tonight. It's something that we actually talk about quite a bit in all of our webinars, and it's the art of abstraction. How do we abstract? That's a basic learning tool that I guess that helps you in your career as a coder, but clinicians use this, providers, lots of people in the medical field learn how to abstract quickly. So we're going to show you how to do that. Let's talk about what abstraction actually is. You know, I started a long time ago working in medical records, and I did analyzing and abstraction is kind of what they titled my job, which I know that's not really a good title, and abstractionist and analyze and abstractionist. Anyway, but that was exactly what I did. I analyzed the records to make sure that everything that needed to be in the record was there, and then I abstracted any content that was pertinent to move to the next step. And one of the great perks about that is that I learned for inpatient and outpatient everything that was in a patient's medical record, all kinds of documentation. And so I appreciate the time that I got to do that for like 5 years. But I actually learned this art of abstraction a long time before that. When I was in 5th grade, we had a brand new teacher, fresh out of school. This was the first year that she was teaching us. And she determined that it would be very beneficial for us if she taught us how to speed read. And so really, speed reading is just abstracting pertinent content out so that you can go faster. Well, I was really good at it, and it helped me throughout my years of studying and going to school and a lot of areas of my life. However, there are times when you don't want to speed read or abstract quickly, like when you're reading a recipe. And so I'll have to, if we have time, I'll tell you that story at the end. But when we think of abstraction, or you go look at the definition of abstraction, or abstracting something, it's not the same in every field, right? So the main definition that you would look at isn't pertinent. It isn't when you're abstracting an art or abstract art, or just the word abstraction itself. However, the closest definition that I could find, and I found a couple of them, was in the tech world, in IT. Their theory, or how they use the term abstraction, is very similar to what we do in medical records. And this particular definition I thought was as close as you're going to get as to what it means for us to abstract the content out of a medical record to be able to translate that into codes. So ultimately, we're taking the essential content and leaving everything else in the background, and not that isn't pertinent to us. I like to call it, abstracting the details and leaving the fodder. But again, this is excellent. It reduces complexity. Again, when we look at an op report, half of the things in that op report we don't care about. We need to get to the details and be able to get to the highest specificity. And over time, we train our brains to look at the details that are going to allow us to do that. So we don't care how the patient was laid out on the table. Were they supine, prone, whatever? We don't care. We don't care most of the time. Anesthesia does their own reports, but we don't have to look at the details on the anesthesia. We don't need to look at the details about placement of a bone when they're articulating, testing it to see that it's articulating and stuff if they're doing a repair. That doesn't translate. That's not pertinent information. But there's information that is pertinent, like, what kind of sutures did they use? Because if it's a complex repair, they're going to use more than one type of suture, and that's a giveaway. When you see, 07 or 04, we don't need to know what those sutures are. You get to where you know the names of them and everything, but the fact is they use more than one type of thread, so therefore they were doing different depths. We also want to abstract if they're working on a joint. If there's parts of that joint that are pertinent for a repair or whatever they're doing to the joint. So I've got examples of that, but this definition of abstraction is the act of representing essential features without including the background details or explanations, because we just know it, right? In the computer science and software engineering domain, the abstraction principle is used to reduce complexity and allow efficient design and implementation of complex software systems. So just like working with software, all of that stuff, it's in the details. We only want the details that are pertinent to what we're doing. And then everything else in the background, we don't care about. We know where to come back and look at it if we need to. Here's another definition of how abstraction works, and it actually comes from an IT background too. And I looked at several ways to be able to describe, the ability to abstract content out, and the IT world, again, is the closest that I think we've come to. So through the process of abstraction, a programmer hides all but the relevant data about an object in order to reduce complexity and increase efficiency. That's exactly what we do, right? We want to reduce the complexity of that report or whatever we're reading, and we want to be more efficient. We want to be able to abstract just the contents that we need to assign the proper code and at the highest specificity. That's our goal. That's what we do as translators, as coders in the medical world. In the same way that abstraction sometimes works in art, the object that remains is a representation of the original with unwanted detail omitted. So when, some people say, I don't get that, abstract art. And the reason why abstract art, what makes it different from somebody that's really good at it versus having a 5-year-old do it, because you're looking at it, you're just like, well, it just looks like thrown paint on a canvas. My 5-year-old could do that. What's the big deal? But there is actually an art to doing abstract art, and it comes down to, it represents something, but you don't focus on the details, the unwanted details. There's something that's going to leap out at you. Maybe it's a use of the color red with everything else, but there's something about the red that pops up off the page, And so same thing with coders. We're looking at this intense information, and we're getting rid of all the unwanted details and just pulling out. Our eyes and our brains will just pull out what needs to be done for the reason we are doing it. So what do we ask ourselves in medical coding? We need to know, what's the purpose? Why are you coding? Is it because you're doing pro-fee outpatient coding? Is this a facility inpatient? Is this are you auditing? Are you doing something with, Medicare? Are you looking for mistakes? Are you looking to clarify a code that was used? Is there something in the details that, this particular code's been used, but it's being denied, so we got to go back and look. It's like, okay, what is it about that code that they didn't like? Well, it's probably in the documentation. It doesn't apply to something, Or are we doing, risk adjustment? Because a risk adjustment coder abstracts different content than an auditor or a facility or a pro-fee coder. Home health coders code for different reasons. And so when you look at it from the viewpoint of risk adjustment versus a coder that is coding for a pediatrician, that information we're not going to abstract. Our brain is not looking for specific things differently. We, the risk adjustment coder, the purpose is not necessarily why that patient was seen that day. It's, can I get any other chronic conditions that were noted? Is there comorbidities or something? Now the documentation, we know what purpose we're doing it for. So if we're coding it as an inpatient coder, the documentation we're looking at is the H&P with the admission details. What are the patient's signs and symptoms? Do they have a definitive diagnosis yet? What tests were done? Do we need to code off the radiology or pathology reports? Can we code off EKG strips? No. Can we code off labs? No. So even the chart itself for inpatient, some of that stuff is omitted or what I would call fodder. We don't care about lab reports. We know that a lab was done because the person has, a CKD, and they need to run labs to see the functioning, the level of function for the kidneys. But do we care what the lab report said? No. We just know that it was done because it's protocol. It would be typical of what we would see in there. So even with op reports in the hospital, person has an appendectomy, we expect to see the history and physical. We expect to see progress notes. We expect to see the op report. We expect to see something from anesthesia. We expect to see something from respiratory therapy after a person has a surgery to make sure their lungs are working well. And then we expect to see a discharge summary. So the documentation that we're looking at is going to be pertinent for us to abstract the codes. Are we going to look at the nurse's notes? No, probably not. Not unless we're trying to clarify something we don't understand. We could look at them and say, oh, okay, yeah, they said this, so I know that's what the provider meant in this, scenario. We're also looking at the details. We need to know from the details if, this is important or not. And again, we have to ask ourselves when we get ready to abstract, what's the purpose? Are we doing it for risk adjustment? What documentation? Okay, so an op report looks a whole lot different than an H&P. And we expect to find different information, meaning we can get a diagnosis off a op report, but off an H&P, we're going to find all of those comorbidities from a risk adjustment standpoint, right? And then attention to detail. So again, I've kind of already mentioned these. When we study, we abstract. Is that why we're abstracting? We're studying to learn about Mohs surgery and how it's done. Are we abstracting information because we're testing? To be able to abstract quickly will make it makes you a better person in studying too, because there's so much information out there when you're studying that isn't pertinent. You don't need to know that. There's a lot of filler words. Now, you have to be careful with that, and I've got examples of that. We're going to go through this. Testing. When you take the CPC exam, you're timed. You got almost 6 hours to take it, and you think 6 hours to do 150 questions? Well, most people run out of time. And so there's an art to abstracting the content, not only from the question, but also from your manuals, picking out the proper diagnosis code, picking out the proper procedure code. Are you doing pro-fee? Are you working in a doctor's office? Do you work for a gastroenterologist? Do you work for a subspecialty? So let's say you work for a pediatric group. But within that pediatric group, you have a pediatric neurologist, you got a pediatric endocrinologist, you got a pediatric orthopedist, and then, so, and a family, pediatric family practitioner, meaning, that's your pediatrician. Facility, again, even with facility work, are you doing outpatient? Are you doing ER? Are you doing critical care? There's even some facilities, even though it's not a facility coding, but some facilities, entities have extensions to them. So they may have a home health agency. Now, you don't code the home health agency's documentation and everything. It's not bundled in, it's different. But if you have an entity that owns a home health agency, as well as a right there, maybe they not contract out, but they lease out for medical equipment, you have a pharmacy, all of this stuff is in facilities. So you may have traces and contact with all of that in a facility. When you're auditing, basically auditing is trying to find mistakes. That's what you're doing. You're trying to find a mistake. And that auditing ends up being part of every type of coding that you do. No matter where you work, you will be audited. And after you've been coding for a while, you'll be asked to audit, to go back and look. Maybe you're asked to audit documentation, not to pull out a code, but to make sure the documentation's meeting the necessity to be able to get the proper code. Are our providers documenting what we need? Do we need to assist them in showing what our translation looks like, what the coding world looks like, so that we're always on the same page? As well as compliance. With compliance, you're not necessarily, you're looking for mistakes sometimes, but with compliance, you're trying to fix an issue. We want to make sure that we're all on the same page. We're obeying the rules, the regulation, the laws, and we need to see if we're going to get off on a tangent, or we're where it could possibly cause a problem because it happened someplace else. And coding is not black and white. There's a lot of ambiguous stuff out there. So you could code things one way or not, So definitely compliance, you'll be abstracting, and risk adjustment. And I put that specifically in there because it's a completely different way of coding. We're looking for chronic conditions. We're only dealing with diagnosis codes. However, with risk adjustment, you have to be able to read all types of documentation. You have to be able to understand the disease process. You're literally auditing out the information as well as abstracting. You're looking for errors like, is that a proper e-signature? Is the patient's date of birth on in the proper place? Are we able, data service, those types of things? Those are auditing, not necessarily coding, right? So all of these serve purposes why you might need to abstract, or why you need to be better at abstracting, from studying to get a credential, or just studying a new procedure that's done, or a new disease process that was discovered. We never stop learning as coders. Then again, testing. We're not just, once you get done with your credential, you'll have CEUs. You'll always be taking some type of a test. And then again, it doesn't matter where you're working, you're going to be exposed to all of these others. So now we're going to get to the nitty-gritty. This is the fun part. And if you've ever been able to have the opportunity to learn to speed read, I don't know, maybe in the 90s, I think it became a big thing where you could get these help books, or videos on how to learn to speed read. It would make you better in life, blah, blah, blah. And I don't have to tell you how old I am, but 5th grade was a long time ago. And when you learn to do something at a very young age, it transfers over in your everyday life, which can be a real blessing, and it has been a very big blessing to me. But it can also cause a lot of problems because my brain is trained to look at something quickly and pull out. It almost makes your brain be a little ADD, and you can often miss things that are important. We don't, I'm trying to think of an example. So if you are religious and you're reading a Bible or religious book, you don't necessarily need to speed read. You need to process everything that you're reading. If you're reading a novel, you don't necessarily want to speed read that. You want to really get in tune and learn the characters and feel the characters. But you can't do that if you're speed reading. It's not, you don't speed read when you want to read for enjoyment. So let's look real quickly at this bit of documentation. And I think I kept the website up so that if we need to, we can look at it. But this is a training area. And so if you were learning something about fractures, this is what you're going to see. Now, I'm not going to read it to you, but you're glancing at it, and at first glance, you have to train your eyes to abstract properly the information that you need. So it's just a bunch of black on white if you try to do it quickly. And again, it depends what you're wanting to learn. So we're going to look at this on another slide. So while I was babbling on, maybe you read it. I don't know. But let's look at this. The first glance. What should jump out at you? Now, this is really pale. I should have used a darker highlighter here. But the word fracture, the word alignment, and the word skin. I actually highlighted those in pale. Those should have leapt off the page at you. All right. Now you think, well, what are we reading about? Well, the first sentence usually tells you exactly what you need to know. Femur fractures vary greatly depending on the force that causes the break. So we know this paragraph is about femur fractures, only femur fractures, and so fractures, but femur fractures. So at first glance, I know this is about fractures. They're going to tell me about alignment, and there's something to do with skin, because what does skin have to do with a fracture? That should have leapt off of your page. Like, what? Skin? And also, anytime you see anything in parentheticals, that's going to be important. So first glance, that's what should leap up off the page at you. So if you're studying, that's how you do that. Even if you're not doing this for education, but say that this had something to do with a case, then again, those same terms. Now we're going to look at this for testing and educational purposes, and then we're going to also look at some case studies, okay? So first glance. Second glance, what should have leapt up off the page? So we got fractures, alignment, and skin. So now I need to know what type of fractures. Femur, and there's a difference because it's in parentheticals: stable, displaced, closed, and open. Now, why didn't I underline fracture again? Because I know they're all about fractures. We're not talking about anything that's not a fracture. So your brain doesn't have to look at it and say, now it's going to say femur, stable, displaced, closed, and open. That's what I need to know. First glance, I know I'm talking about fractures, and there's something to do with alignment. I may not even at first glance needed to do alignment or skin, but it leapt out at me, so I highlighted it. And the more you know about what you're studying, why you're studying, why you're trying to pull this out, okay, some of this stuff's given. So if we knew we were talking about fractures, that we're in our study guide and we're talking about fractures, the word fracture should no longer leap off the page at us. That's can be omitted. That's behind the scenes now, because we know it's all about fractures. But what we don't know is that it's about a femur fracture. That's specific. And we also parenthetically know we're going to talk about something that's stable, displaced, closed, and open. Okay, so at a second glance, everything underlined should leap off at the page. That's what I'm going to learn about. I don't need to read anything else. Okay. And if you know the difference between closed and open fractures and how that relates, maybe you already know that information. It just becomes fodder then. You don't ever have to look at that again because you know it. Now, is there something maybe at a higher detail that you didn't know about that? Maybe. But with just this little paragraph right there, that's all you need to know. And if you already know, you know it's femur fractures, but you already have the knowledge about stable, displaced, closed, and open, you're done. Why even look at that paragraph? You already know the information, so don't waste your time. Now, if you're abstracting for a reason, okay. All right, keywords. Here's the next another section of this article. It should leap off the page at you. First, location and pattern. And again, I apologize, that's very pale pink. I won't do that next time. I'll make sure that it's darker. So the first thing that we know, doctors describe fractures. How? By location and pattern. Right. Now, we're going to pull something out of each one of these bullets because we know there's got to be something important. So at first glance, I'm pulling out the first one, location, second one, pattern, third one, well, torn. And you're thinking, what does that have to do with fractures? Something's torn? Okay. So, or it might be skin and muscle that jumps off the page. But then, second glance, classified. There's how are they classified? So doctors are describing something. We know it's fractures. It's all about fractures. So now the doctors who are the experts are going to tell us something about how they're classified. We know now that they're classified by location and pattern and maybe something else in the bottom. I don't know. Then we're going to think, okay, so location, what do we need to know? We need to know these three terms, distal, middle, and proximal. If you don't know what those terms mean, you would go look those up at that time. Right? And then pattern, different directions. So the pattern means something happens with the direction of the fracture. Now, I didn't read any of that. I know that because I know I'm talking about fractures. I know that this is the doctors telling me, so they're the experts. I know there's classifications. I know that, and this applies to our coding, location and the type of fracture is very important. Quickly, I can determine that the skin and muscle, they're talking about open and closed, right? So I know everything I need to know about open and closed, right? So I'm going to say I don't even need to read that. But distal, middle, and proximal, I need to know what those are. And then different directions. And so if you're studying, you would stop right there and you'd go look up what is distal, middle, and proximal on a fracture, okay? And then you're done. You don't need to read anything else. All right, now I grabbed this and I purposely made it smaller because when you're abstracting content, it's not going to be on a slide blown up and highlighted, right? So when you read something, and this is from that same website, it's an article, I'll look at the first headline, the most common types of femoral fractures include. So I'm moving down the article. I already know that we're talking about fractures. I already know it's all about femoral fractures. So that shouldn't leap off the page at me. However, most common types, boom, I need to know that. Okay. Then anything that's highlighted, you need to know. Same thing happens with your manuals, right? Anything that's highlighted, you need to know. So now I'm going to look at the different things that are highlighted. Now, I don't even have to look at the word fracture because I know this is all about fractures. So again, I didn't underline and I didn't highlight this, but I'm showing you how you do this when you don't have all that already done. So the word fracture means nothing to me anymore, but transverse, oblique, spiral, commuted, and open. Those are now I know those are the most common fractures. And if I don't know what a transverse fracture is, then I'm going to abstract out of that one sentence, right? The only thing that, well, I'm going to show you on the next slide, but right now, first glance, most common, all right, transverse, oblique, spiral, commuted, and open. I don't need anything else. if I know what those are, because what I have gained from that is knowing that they're the most common types. You know, and again, we're talking about femoral fractures. Get where we're going? Good. All right. I just realized that I didn't put up the questions, but I don't think we do questions tonight. All right, so now let's see what's on the next page. If you don't know what those common words, okay, we're not looking at fracture, and again, I highlighted the transverse, oblique, spiral, commuted, and open. Now, I need to quickly abstract out of each one of those descriptions what's pertinent. Okay. Now, if you don't know anything about fractures at all, you're going to spend a little bit more time reading this. But if you do know a little bit about it, then I'm going to go transverse, straight. All right. And you may even read the first sentence there and the description so you understand how they're going to describe each one. Okay. So they're going to say a type of fracture. They're going to tell us what the break is, and then they're going to describe it. So now I know that transverse is a straight fracture and a horizontal line. Okay, that's kind of pertinent, but transverse, ultimately when you look at something and it says it's a transverse fracture, you know it's a line fracture. Oblique, it's an angled. So all I have to know is that oblique is an angle fracture. So transverse fracture goes like this, oblique goes like that. That's what separates them. Don't need to read anything else. Spiral fracture, in circles. All I got to know. All right. Now, again, if we're going to abstract in more detail, now they're starting to tell us how they might happen, but that would be good for the disease process when we learn more. But quite honestly, if you're a beginner, yeah, you would and didn't know more about these, but I'm saying that we probably know a little bit about fractures. So we know transverse is straight, oblique is angled, spiral is in circles, commuted, 3 or more. 3 or more pieces, because a commuted is also like a compound fracture. So it's kind of a crushing fracture. Now I just know that because I've read it, but commuted, 3 or more pieces. That's all I got to know. And then open, sticks out, the bone sticks out. It went out, it could come back through, but it went out. That's what an open fracture is. And then other things though, you notice there's a lot more information for open fractures than all these others are like 1-2 sentences. So that should tell your brain, hey, something about open fractures is different than these others, or otherwise they wouldn't have given us more content. So it sticks out. And then what should also jump out at you is that it's a risk. And what's the risk? Infection. Okay, and longer. Oh, yep, it makes sense. As this infections could happen, it would be longer to heal. It makes sense, right? Because if bone goes outside, is exposed to the outside world, everybody knows that germs could get in it, you know, and stuff. So now, what do we know? We know transverse is straight, oblique is angled, spiral is in circles, commuted is 3 or more, open is sticks out, it's got a higher risk, and it could cause infection, and it takes, you know, longer. You're going to be in the hospital longer. What do you think? Are you getting it? Okay. Now here's some more information. Now I went ahead and blown this up because that was an example of, you know, how you're pulling this information. This is the same article, and I'm just grabbing and repeating pieces that will be helpful. So now we don't need to read the word femoral anymore. We don't need to read the word fracture anymore. And we established, if you noticed earlier, that there was shaft. We could have said, okay, we're all talking about the shaft, the fracture, so the middle part of the bone. It's pertinent that this is going to tell us something about young. And if it talks about young people, then it's probably going to talk about older people as well. You can assume, but young, what's different in the young? High energy collision. So we're just looking at this real quickly, and we know, okay, they're going to tell us something about, frequently, if it's a young person, it's going to be high energy, and they even give examples. So you could pull out car, heights, gunshot wound. Okay, that makes sense. So in other words, that we've established that young people have stronger bones, and it's got to be some type of a powerful impact to break a femur. Lower force. Okay, so if it's a lower force, oh, that would be like an older person. So now we've got young and older. And now we know young is usually high energy and lower force for older people, and they give examples. So again, if we need more information, we can slow down. But if you already know the background, you're just pulling out keywords. That's all you need. All right, now let me go back. I don't want to show you that yet. I want to show you this article. This is where I got this information. So let's say you're a coder. Now let's say you're learning, you're in the musculoskeletal system of your training as an, to become a coder. And this is this is information you're going to see on all of your textbooks, fractures. And then, you were told to go out and look at articles on femur fractures specifically. And so you were given this article. And so you're going to look real quick, right? So if there's anything you don't know, you slow down, right? And if this is something that's completely new to you, you're not going to abstract this information quickly, like I'm telling you. You're going to read it and soak in all the details, right? So there's a time to abstract quickly, and there's a time not to. And so if this is all new to you, the first time you've ever been exposed to fractures and femur fractures, you're going to read this slower. But if you need a quick abstraction because you need to review for a test, or you just want to confirm that you understand something, or you know that you might be tested on this article, then again, we're going to abstract. And the key words, we're not going to look at femur, we're not going to look at shaft, and we're not going to look at fractures, because we know that's what the entire article is about. So when you start to see those, you train your brain not to read those words at a glance. You skip them. Right? That's how you abstract. So really, we know all of this basic stuff. Always look at graphics, though. That's really, really good. Anything that's bubble and highlighted. So here is some of the information that I started pulling out. And you notice I just copy and pasted into there what you needed to know. So we know from here that that we have stable fractures, we have displaced and closed and open. Right there, that's where I got that. So anything in parentheticals, we should take the time to look at. Then doctors describe fractures. Okay, so location and pattern and torn. I picked that, or you could just say injury. Something should leap off there for you. And then everything that's in parentheticals, distal, middle, proximal, different directions. Do we need to know the different directions? Well, how many directions are there? Crosswise, this says crosswise, lengthwise, in the middle. Well, we know that. Okay. And then common types, transverse, oblique, spiral, commuted, open. We glanced at those very quickly because they were highlighted. They were bolded. However, you think, oh, what was an oblique? I know about transverse, because that's very common. But oblique, what was that? Oh, angled. So angled. And you can also, this is how you take notes. You don't highlight that whole thing. You don't have to do anything with the words oblique because they're bold. They leap off the page anyway, but you could underline angle or highlight angle. That's all you got to do. And then that's all your brain needs to know. More pictures. And then again, you can go through and read. And if something's interesting, you're going to stop. It's like, oh, I didn't know that's how they did external fixations. So you stop and you look at that. Right? Very good. So that is kind of how you would abstract for learning purposes. Now we're going to get into another one for testing purposes. This is one of our exam questions, a very basic exam question on the genitourinary system is what it was pulled out of. So again, not difficult. but I'm going to show you how to abstract quickly for testing. So again, it's real easy. That's super simple to read because it's, you know, not even a full UL stands for. You don't even have to waste your time reading this, right? If you know what CKD is, you don't need to read chronic kidney disease. You just know that it's CKD, but you may not know ES. But this is shockwave, and it's extracorporeal, meaning they're going to go from the outside. So that gives us our choice. Well, it's great of them to make number D none of the above, because if they aren't going to be pertinent, then, you know, I'm going to pick none of the above. But a little hint here: when your first characters are the same in a code, then it's pretty specific. So, you know, if it was a 504, 501, 505, that is different. Okay, then it might be none of the above. But this person that wrote this question stayed right in the general area, 5059. So the only difference is a 3, 2, and 0. And so we know that we don't have to go to the index when we're testing. We go straight to the tabular. And it was nice of them because these codes are going to be right here next to each other. So we're going to be able to abstract them extremely quickly and say what's different in them. So being able to rule something out quickly, you can't do that with the choices that we've been given, because we know they're all 5059s, and most likely we're not going to have a none of the above, because we've got specificity within that little area, that category of 3, 2, or 0. Okay. But then the next thing, when you're glancing at this, you're saying, okay, so there's got to be other types of lithotripsy. Now, if you've really bubble and highlighted your manual, then done the bat technique with it, this will be super simple, very fast, right? Because this is probably all in one bubble, and the differences are highlighted for you. So all you got to get to is 5059, and bam, it'll jump off the page at you. All right, so let's look and see what the codes are. We can rule this out extremely quickly, because this is a lithotripsy. And this is an ablation, this is an ablation, and this is a lithotripsy, so it has to be 50590 or none of the above. But we know we're going to rule out none of the above, and it's word for word. So an ablation is not a lithotripsy. What if it said ablation and lithotripsy or something like that? That's fine. But you could, this was so simple: ablation, lithotripsy. Yep, it's lithotripsy. That's the one it is. Even if it said cryotherapy or radiofrequency, those are not lithotripsy. So see how quickly, and actually these codes would be in reverse order. So the person that did this, you know, did a great job, because they reversed the sequence, and they picked codes that were right there next to each other. So if you guess, it's really hard just to guess, but you were kind of able to rule out none of the above. Now, if they all said, if this next one had said ablation, all three of them said ablation, then you would know it's none of the above, because an ablation isn't a lithotripsy. Just quick. And if you knew what an ESWL was, you don't have to read the rest of it, and you just look for lithotripsy. And you don't have to go flipping around pages or anything. It's going to be right there all together. Super simple. Super simple. Excellent. Now let's get into some more fun. Let's do a case. Let's abstract it. So I've pulled it out of sections. So the chief complaint. We can get a lot as a coder from the chief complaint. The chief complaint may not be the reason why the patient's there, but off the chief complaint, there's a few things that should leap off the page at us. One, first visit, right? So we know this is a first visit. So if we're doing E&M, what does that tell us? It tells us that this is not an established patient. This is a new patient. So when I look at this, the first thing that I see is first visit, gallstones. All right. Everything else, you know, nothing else is really leaping off at me at this time. Okay, so very simple. Chief complaint. Now, this is a different story. Now I'm going to leave this up, but I'm not going to read it. Okay, and I want you to kind of just peruse it. Don't read it, and look and see what out of the HPI that should leap off of this image for you. Okay, so wherever you see like things like where someone was at, that's not pertinent as the coder, right? Dates, usually not important. Time appears like 3 times, 6 to 9 months ago. Stuff like that's not, we don't diagnose, that isn't part of the diagnosis, right? So again, just kind of give that a perusal, and it just may all look like fodder to you. Maybe it's too much. So what we're going to do is I'm going to show you what leapt off the page for me. Everything, if I'm doing E&M, so if I'm just doing regular coding, the HPI always has a lot of E&M information in it to be able to get to the E&M. We already know that she's a new patient because it's a first visit. So that's first part of E&M. What is going to leap off the page for me? Things like, okay, hospitalized 3, gallbladder removed, pain's worse, right upper quadrant, severe intensity, frequency, all right, because I need to know the frequency, several times a week. Aggravating factors, boom, all right. Bloating, severe intensity, frequency, several times daily, duration, aggravating, nausea, severe, blood and stool, times a week, diarrhea. These things are just like flipping off the page at me and saying, hey, look at me, this is pertinent stuff. Okay. So from an E&M perspective, we want to know that all that stuff was evaluated. The severity, the intensity, the aggravating factors, and anything else that the patient has going on. Duration even could have been underlined. But as we were going, we already got most of that. So, okay. Now, from a risk adjustment standpoint, not an E&M, but let's say you're coding it for risk adjustment. Hospitalized 3 times, gallbladder, right upper quadrant pain. Nothing else is pertinent to me because I don't care what their signs and symptoms are. I want to get a definitive diagnosis, and gallbladder doesn't risk adjust. However, the patient was hospitalized 3 times, so that tells me that I have either already seen those 3 documents, or I may see more tests and results and stuff like that because the patient was hospitalized 3 times. So this is going to tell me this is going to be a large chart, at least for that. I know what happens when a person has gallbladder trouble, and I know that right upper quadrant pain, you know, is significant. So if she had her gallbladder removed, then why does she still have right upper quadrant pain? You know, now I'm abstracting very quickly here, but I don't care what the aggravating factors are. I need to know that they were addressed, but I only need to see one thing that addresses it. You know, and the fact that she was hospitalized and I see all of this stuff, oh yeah, we've got plenty if we get a definitive diagnosis. Then this, she was told she had to have. Okay, now let me go back. I want to show you something. Up to this point, did you think that she was there because her gallbladder was messed up? Or did you think, hey, she had her gallbladder removed and there's something else going on, right? Now, this is where you can trip yourself into trouble, but by the time you get to the end of the document, you would know. But you have to pay attention to some details. So when I look at this, I saw hospitalized 3 times, gallbladder removed, right upper quadrant abdominal pain. Okay, and that would jump out at me no matter what type of coding I was doing. However, if I was abstracting very quickly, I would assume that she had had her gallbladder removed and there was something else going on because I'm abstracting very quickly. But then I would have gotten there and thought, you know what? You don't have all of these issues after you have your gallbladder out. I don't even have to read them and know that, but I would have been thinking a higher level of something going on, because just because you had your gallbladder removed doesn't mean there isn't other things that would cause these problems. Now, when they remove your gallbladder, they look at your appendix, and usually if it's even slightly, messed up, they'll go ahead and take it out. So it's not appendix, and appendix doesn't cause all those other, that many issues, but I could be looking at the pancreas, something to do with the liver. There's still things in that area that will cause all these signs and symptoms. So my first glance, I'm thinking, okay, she was hospitalized 3 times, gallbladder removed, right upper quadrant pain. So I have to determine, was she hospitalized 3 times with right upper quadrant pain and her gallbladder was removed, or, because this is the HPI, or was she being seen in this encounter for right upper quadrant pain and she had her gallbladder removed? I know she was in the hospital 3 times. And I was like, okay, no, I need more information, right? I can't make assumptions. You don't, so you really don't have this much in an HPI if something isn't going on. And then this clarifies it. Was told she had to have her gallbladder removed. Those are not things, that is fodder to me. Those little words are not going to leap off of the page at me, okay? Unless something doesn't make sense, then I got to go back, more attention to detail. Oh, she was told she needed to have her gallbladder removed. She's been in the hospital 3 times. She presents with right upper quadrant pain, abdominal pain. Okay, she's got a problem with her gallbladder, and yeah, all of these are, signs and symptoms that I don't even need to spend time with. If there's nothing new here and I'm looking quickly and I see nothing that isn't dealing with a gallbladder. So from a risk adjustment coder standpoint, gallbladders don't risk adjust. However, for CMS HCCs, but for HHS HCCs, they would. So, or you might be doing a complete capture where they want you to do it. But a risk adjustment coder, depending on what type of risk adjustment you're doing, you don't care about all this stuff once you've got one line to determine that diagnosis. So let's look at the physical exam. I'm going to glance through that. Now, the physical exam is when the provider's actually, touching the patient. He's, going to determine what's going on. And I'm looking, and most of this stuff, depending on the format that they use for the EMR, words like normal, whenever it says normal, okay, yeah, usually everything's normal. But if you notice, mild right upper quadrant tenderness, hyperactive bowel sounds. But they don't have anything else going on there. But absolutely, we have a line for gallbladder now. Yeah, she's got a gallbladder problem because, not just in the HPI, but in all those signs and symptoms and stuff, he palpated the abdomen, there's tenderness, and he listened, and there's hyperactive bowel sounds. So everything else is pretty much fodder. Your eyes have no pertinence to your gallbladder. Cardiovascular could, psychiatric could, because they, appropriate effect and demeanor for what's going on, but usually that stuff, respiratory, not usually going to have any problems. So we know this because we've abstracted so many times. After a while, this just becomes common knowledge, and it allows you to go even faster. So here's the assessment and plan. And we really get our definitive diagnoses from here. But again, you have to think about this. Are you looking at it from an auditing standpoint? Are you looking at it from a risk adjustment or a pro fee? What are we doing? So the assessment, hey, we do not have a definitive diagnosis, do we? We have the upper quadrant pain, bloating, nausea, and stool, blood and stool, and diarrhea. He did not say cholecystitis. Now, that's what we would be expecting, but he didn't. So therefore, as a pro-fee coder, outpatient coder, we're going to code those signs and symptoms, because we know that the plan is to do a cholecystectomy. Why do you think he didn't say it was cholecystitis? Because until he gets in there and looks, he doesn't really know. And he knows he's going to go in there and look. So why give a definitive diagnosis that may be not cholecystitis, but might be stones or something like that? So he chose to do, these are all the indications of why I'm going to do a cholecystectomy, right? And then from a risk adjustment point of view, none of that risk adjusts, but from the op report, we'd be able to, then he'd say cholecystitis or stones or whatever, okay? See how quickly we can abstract that out and come to a determination. Now, this comes with practice, guys. The more you do it, the more you understand the disease process, the more you understand medications that are given for what diseases, the treatments that are involved, makes you faster at abstracting, and it also makes you have the ability to get to a higher specificity. Don't let yourself get tripped up, because once you start doing this, you'll make mistakes. There are times that you have to read, and there's other times that you can abstract and pull, right? So if you're learning something new, take your time, but practice that art of abstraction when you go to highlight or to underline or make yourself a note. Okay, don't highlight and underline everything. Use these techniques that we talked about to just pull out the pertinent content so that you can train your brain to do that. It takes time and practice to do it. But again, the more you do it, the better you get. Now, I'm going to tell you real quick, because I think that's the last one. Yeah, real quick before we close, because we've got a few minutes. The errors of your ways, if you get to doing this, you'll screw up. So you can trust your gut, but in the beginning, this is an art that's learned, okay, and you will get better with time. That's why practice exams are so important if you're learning, or as you're out there coding real documentation. So again, I told you when I learned to speed read, and I do it frequently. So when I look at anything, my brain picks out only the pertinent content. I have to force myself to stop and read or absorb whatever I'm looking at, whether it be a sign, whether it be anything. Because if you look at a speed limit sign, you already know what to expect. So if you see a 4, it's 45. If you see in Texas, if you see a 7, it's 75 because we can go 75 in Texas, things like that. And your brain automatically knows. However, if you're looking at a sales ad, your brain is going to say, what's on sale? What's the price? Right? You don't have to read all the other colorful stuff. But your brain makes assumptions when you do this for very long, and it often makes wrong assumptions if you don't have any background to base it on. So if you're driving down the road, when I'll see signs advertising things and stuff, and my brain will make assumptions what those words are, and it's usually not right. And I've come up, it's like my brain tells me, literally says, apple orchard, and but it may say, it may look at the A and it might get apple, but I might be thinking about buckets of apples or something, and it'll say apple bucket, not orchard, or apple restaurant, or it just makes assumptions. So again, that can be a problem. So then my quick story is that after I got married, I wasn't a very good cook, and my mother was a fabulous cook. I never had to cook very much. So I decided I was going to make a roast because his mother made wonderful roasts. And I said, okay, I bought this roast. I put the potatoes, the carrots, and everything's in there ready to go. But, because I found this recipe, but you know, how do you get a recipe for a roast? You just put all the stuff in. So I had looked at it and I was like, I got everything in there, and it says to cover it up. I've got everything in there, but the recipe did not tell me how long to cook it for, which I thought was really, really odd. And again, you know, my brain, I was so excited. I only, you know, I got the pertinent information, especially because it's like a roast. How can you screw up a roast? And she said, well, cover up with foil and cook it for 2 hours. And whatever you do, don't open it up. Don't take it out. Don't open it up until the 2 hours are done. Got it. So my husband comes home from work, and it's, you know, got like, you know, a whole hour left. It's only cooked for an hour. He says, you know, that roast smells done. And I said, no, it's not done. Your mother told me 2 hours. And so the 2 hour, after another 30 minutes, he goes, honey, you know, this really smells done. I think you should check it. And I said, I'm not going to check it. It's got 30 minutes left. And your mother said, absolutely not. Do not take it out and do not open it up. Whatever you do, it will be messed up. And so, and I mean, the whole house, we had a tiny house. It smelled so good. And I'm thinking, he just kept hounding me about it. I was like, fine. I'm going to take this roast out, and if it's ruined, it's your fault, not mine, and you have to call your mother and tell her that you ruined the roast because you made me take it out before the 2 hours were up. And he's like, okay. So we take it out. Oh, it smells wonderful. We open it up, and my big, beautiful roast was about this big, and it was black. And I just burst into tears, and I'm not a crier. And I was like, what went wrong? I did everything right and everything. And he said, well, how long? He said, you sure you put it? Yeah, 2 hours. And he goes, well, he looked at the oven, and it was set at 500 degrees. And he said, how come you set the oven at 500? Because the recipe said to cook it at 500 degrees. And I called your mother, and she said 2 hours. And he goes, you don't cook anything for 500 degrees for that long. It's like, well, that's what the recipe said. And I got out the cookbook, the big Betty Crocker cookbook or whatever it was that I'd gotten for a wedding present. And I said, right here, it says word for word, cook for at 500 degrees for 15 minutes, then turn down to 250. Oh, shoot. Because all I wanted was the temperature. I didn't want the rest of the information. So I abstracted out 500 degrees, boom. Didn't know. I looked twice, 2 or 3 times, didn't say how long. So I just asked my mother-in-law. And that is one of the most graphic, most fun descriptions of when abstracting doesn't always pay off. You got to pay attention to the details. And if you don't know enough about what you're doing, you're going to make errors like that. You're going to burn your roast. And he was such a sweet guy because he said, I think I can eat this one corner. And he tried. And he goes, well, it kind of tastes like jerky. And anyway, we had a good laugh out of that. Now I can cook very well. So be careful. Don't abstract if you don't have the background knowledge and the skill to do it yet, but practice, practice, practice. It's all about what we do. Don't forget that if you have any questions, you can ask them in the CCO Club. We now have CCO Club Prime, which is the best way to get your, not only your questions answers, to pick your courses. And we have courses in pathophysiology. We have courses coming up in pharmacology, but compliance are some of those extra courses that if you're already a coder, that will make you even better and make your abstracting skills better than what they already are. All right. Bye, guys.